Assalamu alaikum,
All right,
everyone.
so
Sorry for
I would
the
request
delay.
everyone to just turn off their mics and we can have the question answers at the end of the section. For the queries, you guys can write them in the chat box, which will be entertained by the end. Thank you. Dr. Azhar, please.
Yeah. Assalamu alaikum, everyone. Sorry for the delay. Um, so today I'm gonna talk about the pain management in polytrauma. Initially, the topic that was assigned to me was the orthopedic surgery pain management as well. But I talked to the admin people, and I informed them that it would take a much more time. So due to the limited time, I'm right now I will talk about the pain management in polytrauma only. In the next lecture, that would be rescheduled. That would be scheduled some to some other day. I will talk about the pain management in the orthopedic surgeries. So first of all, we should know about the polytrauma. So polytrauma basically is the Abdullah. Could you please navigate the slide? Abdullah, are you there?
Yes, sir, I'm there. I'm just trying to have some help.
Yeah. Next slide. Yeah. By definition, if there is concurrent injury to two or more body parts or systems that results in cognitive, physical, psychological, or other psychosocial impairment and functional disability is called polytrauma. So it is very important to differentiate between the polytrauma and the other types of trauma as well. Next slide, please. So, in a national trauma registry from Pakistan, from the trauma center Karachi, the blunt trauma was found to be the most prevalent, accounting for nearly around 75% of all the injuries, followed by penetrating injuries. Could you please click on it? So here you can see that the road traffic accident is the leading cause, accounting roughly around 59% of the cases. And blunt trauma accounts the topmost, that is roughly around 74% of the 74.9% of the total trauma, followed by the penetrating injury. Yeah. Next slide, please. And if you see this data, you will find that the limb fracture was cited as the most prevalent, followed by the brain injury. So here you can see the different long bones and upper limb bones. People come with the trauma to the trauma center Karachi. Mostly it affected the long bones and the upper limb bones, followed by the traumatic brain injury. So this is a data from one center only. So if we have registry from other centers as well, we can have a more focused data of the injury, and we can find the how much grave is this problem. So 91% patients with trauma presents to the emergency department with the complaint of pain, and up to 50% of the trauma patient receive the inadequate analgesia. This data is from the Western world. And even if we talk about the chief complaint with which the people come to the emergency department, again, 75% of the patient comes with the chief complaint of the pain. But here we are talking about the trauma. So pain in trauma has a role similar to the double-edged sword. On the one hand, pain is a good indicator to determine the severity and type of injury. On the other hand, pain can induce severe complications and it may lead to further deterioration of the patient. You can see, I'm sure you must have seen the patient, a number of patients in the ICU, especially, that due to the untreated pain, those patients develop complications, which we'll discuss later on, and a patient which could be saved only by definitely after the definitive treatment with pain management, we were unable to save those patients. So it is so much important. So untreated or inadequate treated pain intensifies the effect of trauma on each and every body function. Respiration, hemodynamic stability, and renal and gastrointestinal function, leading to an increase in complications. The poorly managed traumatic pain is also associated with a variety of downstream harms, including the chronic pain, the post traumatic stress disorder, and longer intensive care unit and hospital stay. That obviously will also affect on the patient financial status as well. So the main goal is a tolerable level of pain. That is a level of pain that is acceptable uh, to the patient and allow them to function at a minimum. Again, you must have seen these surgeons who do not allow you to treat a patient with a pain. They have in their mind, they think that if the patient's pain is treated in the emergency department, they won't be able to make a clinical diagnosis. So this is an old idea with the development of modern equipment, with the investigations and other methods we have. Now it is advised to treat the pain so as we can patient may achieve a comfort level, and a diagnosis can be made by doing the imaging and the other techniques that are available. So basic measures suggest that include early assessment of pain in patient with severe trauma, using pain rating scale adapted to the patient's age, development level, and cognitive function, and rapid management of pain. So again, it is very important that we have to go up to the patient's level. We have to make a primary assessment to see which scale uh, we can use on a specific population of a patient. So you have to inquire about the onset of the event, uh, the provocation or palliation. Abdullah, please, next slide. Yeah. Then quality of the pain, region and radiation of the pain, severity of pain, and time. That is the history of pain. That is very important. So there are different scales that can be used, such as visual analog scale and numeric rating scale that could be used. There are age-specific, next slide, please, scales that we have, such as we have pain scale in infants and up to the age of 4 years. We can use the FLAC scale. And to the older adults, we have visual analog scale, numeric rating scale. Although these scales does not cover each and every aspect of the pain, but it would help in giving you a direction and would help you to start the initial treatment of the patient. Then again, even in ICU patient, click it again, Abdullah. Yeah. So we have critical care patients pain objective tool as well. So you can even do the pain assessment in the ICU patients as well with low GCS. Again, that is very important because by doing the appropriate pain management assessment, you can plan a appropriate tailored pain treatment therapy. Yeah. Next slide, please. Yes. So, careful examination and understanding of the complexity and multifactorial nature of pain ultimately determine the rationale for prescribing analgesic medication, as I have already told this, and recommendation of pain management plan. Early initiation and appropriate treatment is very important. Aggressive use of multimodal therapy, which is the main principle nowadays in every pain management strategy. Treatment of the underlying cause, that is very important. Without fixing that issue, especially in a polytrauma patient, you won't be able to sustain these things long. And assessment and management of the psychological and psychosocial factors as well are very important, depending upon the nature of that polytrauma. So all these may affect the treatment or contribute to development of the chronic pain if not addressed appropriately. So if you go through the literature has suggested that the pain management in the injured patient follows the similar principles for managing acute postoperative pain. And that's why it is important that multimodality treatment strategy be used whenever possible to minimize the narcotic use, especially if the patient is, if there is suspicion of having low GCS, or there are chances of having uh, patient may drop the GCS. So especially in such cases. Even in general, nowadays it is recommended to use the narcotics as minimal as possible. So yes, next slide, please. So most emergency department have pain assessment and management protocols that take into account the patient's hemodynamic status and clinical condition, and give preference to non-pharmacological approaches wherever possible. So, in a study that was published in 2020, it recommends the use of local anesthetic agents, paracetamol, and NSAIDs for simple isolated trauma. And continuous intravenous lidocaine infusion was also recommended safely and has been used successfully in multiple injuries. So that has its own indication that we are going to discuss in the next few slides. The treatment of trauma patient. Next slide, please. The treatment of trauma pain in the pre-hospital setting and in the emergency department largely similar and consistent, mainly of it consists of mainly of paracetamol, NSAIDs, nitrous oxide, and opioids. So these are the recommendations. You can go through the European Society of Pain Management for Emergency Department. They have recommended nitrous oxide as well. NSAIDs do not normally have a role in major trauma due to their deleterious effect on coagulation. So whatever medication that you are using, you should know the contraindication and limitation of that drug or of the patient comorbidity as well. Nitroxide has a long record of safety and has fewer side effects. However, it may not be used until pneumothorax has been excluded and its contraindications, which also include the first and second trimester of the pregnancy. So we have to avoid these things as well. So for that, you should have a brief history of the patient as well. Yeah. Next slide, please. Yeah. Shorter acting opioids such as fentanyl and L-fentanyl may be used for rapid pain control. Intravenous morphine alone or with or without ketamine suggests the greater efficacy of combination therapy. Paracetamol may be given intravenously and is a useful adjunct to other stronger drugs. There are a number of studies that have shown that if you're using paracetamol IV, it reduces the requirement of the opioids up to 70%. So it is a very important medication that most of the time the people, general public, they think it is its use should be very limited. Efficacy is not that much as compared to the other medication. So next slide, please. So one should look for the non-pharmacological approaches that also play an important role in improving the pain and trauma. This include immobilizing limbs and applying dressings or ice packs, and these approaches may be used in conjunction with the drug therapy. If there is a hard backboard that should be removed at the earliest, which is used during the shifting of the patient. Cervical collars, most of the time it is applied if there is a suspicion of the cervical spine fracture. But once it is clear, it should also be removed. A splint or immobilizer should be used in the fractured limb wherever possible. And only perform painful procedures, maneuvers such as DRE examination, NG tube insertion, Follis catheters, and log roll when specialty indicate. Uh, Sometimes it happens that people do it in a routine way. So if there is an indication for any procedure, only then it should be done. Next slide, please. So most polytrauma patients who are not dynamically compromised but are in moderate or severe pain should be treated with a parental opioid as first line of therapy. Now, it also depends upon the GCS of the patient. So there is no one strategy or no single medication that is indicated in every patient. We have to look for the indications. We have to look again for the contraindications, and we have to look for the patient status as well. So, if vascular access is delayed in a patient in severe pain, it is appropriate to administer the initial dose intramuscularly or subcutaneously. So, you can give the morphine or any other medication that is available intramuscularly while you are using for to achieve the IV access, especially in a patient who is coming with the shock. In shock patient, it is sometimes become very difficult to get the IV access. Yeah, next slide, please. So, trauma patient in shock present an analgesic challenge. As we know that any potent analgesic will act as a sympatholytic. Sympathetic tone will get decreased in this context and could worsen the hemodynamics of the patient. You must have seen a number of patients in the operating room where after getting the general anesthesia or after giving the strong opioid, a patient loses their sympathetic tone and suddenly patient goes into the septic, any type of shock with a sometimes unrecordable blood pressures we find. So therefore, treatment of pain is appropriately deferred until a central perfusion is restored. So resuscitation again, we have to weigh again the risk versus benefit while we are treating a patient in such a situation. So early intubation of the polytrauma patient in severe pain who's clearly headed for the operating room accomplishes a variety of goals simultaneously. In addition to securing the airway, the properly induced and intubated patient is unconscious and therefore free of pain and emotional distress. Still, to facilitate imaging and easily anesthetize for painful procedures or surgery if indicated. Fortunately, these patients usually have a diminished level of consciousness and diminished memory of their resuscitation. However, when perfusion and mental status are improved, prompt assessment and treatment of pain returns to higher priority. Similarly, in such a case, although it's not a topic of discussion, some patients with who comes with a polytrauma, having a very profound type of shock, even under general anesthesia, there are number of cases where the patient experiences the awareness under the anesthesia. That is again, we have to risk against the risk versus benefit. So it's better to have a patient with awareness alive rather than a dead patient. So again, it is very important. And later on, we can explain to the family and to the patient as well that we were aware of these risks, but we took this risk just to save your life. So next slide, please. So again, if we talk about the specific area, there's a study in which they have recommended the for thoracic surgery or chest trauma. Again, they have recommended the use of multimodal analgesia depending upon the indication and contraindication, and said is recommended along with the paracetamol, ketamine. Again, it has a very good role in managing the as an adjunct to the regional anesthesia or while waiting for it to be performed. It can be given dexmedetomidine that provides the analgesia at just minor level, and gabapentinoids, again, it has a role in it. IV lignocaines are advised, and steroids have a limited role in it. Um, but these are the medications, and I think these medications nowadays are available in every center. Uh, and there is not a big issue for the cost as well. So, depending upon the available resources and availability of the medications, one can design their own guidelines as well. So, for the chest trauma, if we talk about the nerve blocks, along with the multimodal analgesia, systemic medications, uh, it is recommended in the guideline that for the unilateral, if there is no flail chest, systemic analgesia alone is sufficient. But if there is a unilateral fracture of the lateral or anterior portion of the ribs, it's quite a painful situation whenever patient will breathe. With every breath, patient will experience excruciating pain. So for that, serratus anterior plane block is advised, but it covers the lateral, anterior lateral aspect of the fracture as well, and it covers usually the T2, T8 level. So for the unilateral flail chest, a paravertebral or erector spinae block can be done. And for a bilateral and or more than six ribs are involved, then thoracic epidural is indicated. Again, thoracic epidural has an edge over the other modalities that it you can place the catheter for up to 3 days as well, um, or as much as it is required. But for the single shot block, you have to repeat the block after every whenever the block will wear off. You have to repeat it. But if you are using the catheter, which is very uncommon in Pakistan, but if you are using the catheter, then obviously um, the other plain blocks that are more recommended rather than going for the epidural because it has a number of other side effects, and on the top of it is the hypotension. Similarly, for the pelvic fracture, thoracolumbar analgesia from posterior tap block is advised. Quadratus lumborum block can be used, and again, lower retrospinal block that can also be used. That is mentioned in few studies. For the upper limb trauma, different approaches of the brachial plexus block can be used depending upon the bones which are involved. If periphery, if this proximal area is involved or collarbone along with the shoulder joint is involved, you can place the intrascaling block to counter the acute pain because of that trauma. Supraclavicular block can be used, axillary block for the hand and for forearm can be used, and peripheral individual nerve blocks can be used for isolated bone fractures such as radial fracture or for ulnar fracture, you can use radial median nerve as well. IV regional anesthesia can be used again, but again, you have to keep an eye on the toxicity as well because that requires a double tourniquet as well. So IV regional anesthesia, although it is recommended, but it's not a very favorable thing that we can do. Then in lower limb trauma, yeah, lumbar epidural can be used. Lumbosacral plexus, although it is written in few articles, but practically it is very difficult to achieve the desired effect, and a large dose is used to perform this block. So compartment block, facial iliac block, and peripheral nerves such as femoral, sciatic obturator nerves can be blocked depending upon the site of the bone that is involved. Okay. So there are some serious concerns such as compartment syndrome. Especially orthopedic people, they are very much afraid of having the compartment syndrome that may go unnoticed if you are using a nerve block or a brachial, for example, in upper limb, if you are using brachial plexus and the humerus is fractured, they have a concern that if compartment syndrome is developed, that would be go unwitnessed. But with the recent literature, it is advised that we can use the nerve blocks and for if the surgeon is in a fear of having the compartment syndrome, they may leave a drain in it. So similarly, there are certain other blocks as well that can be used There is one block that is called hematoma block. If you cannot perform a specific nerve block, uh, could you please go on the previous slide? Previous slide. Some serious concern, Wali. Yeah, fine. So directly you can inject the local anesthetic into the hematoma. That also literature has said it also provides very good analgesia. But again, this practice is very limited in at least in our setup. Then there is the concern of having anticoagulation, and if the patient is in shock, then we have to look for it. Should we go for these blocks or not? Because there are a few blocks that may also, as a complication, may do the sympatholysis as well. And there are chances of having the local anesthesia toxicity, especially if you are using multiple blocks. Yeah, next slide, please. So where there is a direct computation with the ATLS resuscitation objectives such as threatened airway or treatment of shock, um, we have to avoid the use of regional anesthesia. Um, Similarly, where direct harm may be caused, such as neuroaxial anesthesia in the presence of raised intracranial pressure, if you're attempting the epidural, it is advisable, it is more sensible to avoid this thing. Similarly, injuries mandating general anesthesia for definitive surgical treatment, such as neurosurgery, inability to position the patient for procedure, such as spinal cord immobilization, um, when consent cannot be reliably be obtained, it's better to avoid it. And safety concerns due to uncooperative patient, such as patient is intoxicated, illicit drug use, or having a combative behavior, again, is very difficult to perform it. So it's better to avoid. Similarly, we have to look for the standard contraindications such as patient refusal if patient has a known allergy to the local anesthetic agent. And if someone is not very much trained in placing the regional blocks, if there is a lack of equipment and care bundle, so it's better to avoid it. Um, Similarly, you must have seen that sometimes uh, patient is having underlying nerve injury, which goes unnoticed. So in such a case, if you are going to um, place a nerve block, always assess the limb function. And if there is a nerve injury, always document it. It will save you. Okay. So a little bit about the burns. So we are not gonna going into a detail. So again, in the burns patient, the first thing is that we have to do the assessment of the pain. That is very important. Uh, Opioids and regional anesthesia and non-pharmacological treatment has a pivot role in it. So next slide, please. Acetaminophen NSAIDs are generally safe and effective for pain relief. However, the choice to use them should take into account the patient's overall health, the kidney function, and the surgeon's preference. For patients with neuropathic pain or those who don't respond to standard treatment, adding medication like gabapentin or pre-gab to opioid therapy can be helpful. Ketamine is a good option for procedural sedation, and providing the medical staff is properly trained and monitored. Low-dose ketamine can be used alongside the opioid to help reduce opioid use, especially after surgery. The use of IV lidocaine for burn pain management cannot be recommended at this time as a first line of agent. But it is a reasonable second or third line adjuvant to talk about the level. It has a level D evidence in it. And given the lack of evidence of the potential legal and political obstacle, we are unable to make a recommendation for the use of cannabinoids. So, in the in a nutshell, you can say that gabapentin, pregabalin, to counter the neuropathic pain, it is advisable to use it at the earliest. Then, although the level of evidence is level C, ketamine has a good role in controlling the pain. Then, ibuprofen, along with the other medication and opioids, have a role in it because the burn, depending upon the degree of the burn, um, usually the patient coming with the burn has a very severe pain. And along with that, there are chances of having some infections and other things as well, which complicated the uh, pain as well. Okay, next slide. So there are certain factors that are associated with the development of persistent pain after trauma. If the patient is of younger age, having multiple surgeries, and acute pain is poorly managed. And if there is underlying nerve injury during the course of trauma and duration of disability, that is time to return to work. If it is prolonged, there are more chances of having persistent pain after the trauma. And psychological factors such as if the patient is very anxious, having depression or under stress. So that patient is at higher risk of having persistent pain after a major trauma. So it is fortunate that we have a local trauma registry, but the valuable data does not include the pain metrics in the published data set. Uh, this is the data registry from the Trauma Center, Karachi. While the registry offers a comprehensive insights into various trauma-related outcomes, incorporating the pain as a recorded variable that could provide additional layers of understanding to further enhance patient care in trauma cases. So this was the just brief review of the trauma management, pain management in a trauma patient, in a polytrauma patient. Um, First of all, we should realize the importance of pain in a trauma patient. Then assessment of pain is very important. And later on, we have to take the non-pharmacological actions. Along with that, the pharmacological medications. And we should know the um, indications, contraindications, patients' comorbidities as well. We have to take into the account, which is very important because most of the patients which are coming with a polytrauma, with a serious polytrauma, there is a very limited time to get the information, to get the history of the patient. So in such a case, there is a very big chances of having a mishap, and we may give up any medication that is contraindicated to a patient. So again, to reassess the things, to relook our management again and again, and once the patient is hemodynamically stable, it is very important to relook our things and manage according to the patient. We should tailor the pain management according to the patient's comorbidities. Thank you. Questions, please?
Assalamu alaikum, sir. Can I ask?
Yeah, please, sure.
I am Dr. Asam. I am a consultant pain physician in King Salman, Medina.
Yeah,
First of all, thank you very much, sir, for very informative and a comprehensive talk on pain management regarding trauma and orthopedics.
yeah,
And that's refreshing our knowledges. Two things I have to discuss with you.
yeah.
First, you
Yes, please.
mentioned that gabapentinoids are the first line drugs for acute chest trauma. But most
Yeah.
of the time, these gabapentinoids are reserved for the chronic neuropathic pain. So, what is the role of these gabapentins in acute chest trauma patient? One question.
Okay. Yeah, yeah,
And the second question is, uh, what are the pain management options for a painful knee joint post TKR?
okay.
Thank you
Akshat,
very
coming
much.
towards the first part of the question, although, as I have mentioned earlier, as a general principle, that if a patient who is coming with any injury, such as for trauma on the chest, blunt trauma, having a flail chest, or having a rib fractures multiple, the first aim is to minimize the pain at the earliest. Because if the patient is in pain, there are chances of seeing a patient who develop the complications such as atelectasis followed by the pneumonia. So for that, we have to use the short-acting opioids, which have rapid onset of action, such as fentanyl, L-fentanyl, um, these type of medication. Once the patient is settled, then we can go for the gabapentin, although the as a first line of treatment, but it will take time to achieve the its peak effect, and sometimes it may take 12 hours, it may take 1 day or 2 days as well, depending upon the patient to patient. But in general, it may take hours to achieve its peak effect. So the ultimate goal we can achieve by placing the local anesthetic agent to the site of injury. That is, we can use the serratus anterior block or erector spinae block or quadratus lumborum. So that is the definitive treatment for the trauma to the chest. The second question, sorry, what was the second question?
So it is the pain management for a painful knee post
Yeah.
TKR. Patient has a TKR about 2 or 3 months ago, and now he came to your clinic, pain clinic, with a painful knee. So what are the treatment options?
Okay, then again, if depending upon the history, if the patient has developed the pain after a few days of the surgery, we have to look for the any sign of infection, or if the prosthesis that is used is very much tight, or if it has some fitting issues that need to be readjusted. So you can give the intra-articular medications as well, steroid as well, or along with that, you can give the ketorolac. Sometimes there are some practices that surgeons do. They can give the intraarticular medication such as ketorolac. But again, this is not the first line of treatment. Depending upon the severity of pain and limitation, how much the movement is limited, you can give the simple NSAIDs to the patient. Oral NSAIDs can be given. Along with that, gabapentinoids can be added. That may help because most of the patients who are coming with the for a total knee arthroplasty, they have a long history of knee pain, and they must have had been using the pain medication. So those medications, such as gabapentinoids, they have a better effect on it. Or for a time being, you can give a nerve block, such as you can give a femoral nerve block and ask the patient to get the physiotherapy during that time period. So these are the simple
Sir,
things that can
hello,
be done.
sir, assalamu alaikum. Sir, what is the role of
Welcome, sir.
Nalbin in pain? Nalbin का क्या रोल है पेन में और ये शॉर्ट एक्टिंग है लॉन्ग एक्टिंग है कैसी है
Nalbuphine, hello.
Nalbin?
Yeah, yeah, nalbuphine can be given for the pain, but in most of the cases, it is not recommended as a first drug of choice. The bad thing in nalbuphine is that it has a ceiling effect at a dose of 20 milligram. So when you have reached at the 20 milligram dose, it will not benefit to the patient. But again, I'm not saying that it's a garbage medication. It should be given. Even in our setup, round the year, we don't have the pethidine or morphine round the year. So in such a case, we give nalbuphine in most of the cases in our patient. But again, the principle that we have to stick on is the multimodal analgesia. We have to give the NSAIDs, paracetamol, and other groups of medication along with the nalbuphine.
Thank you, Dr. Azhar.
Uh,
Similar question being asked by two participants. What is multimodal analgesia? So you had explained it quite nicely, but in a recap, if we can summarize the term for those participants again.
Yes, actually, if you go on the physiology of pain, Uh, yeah, there are different mechanisms of pain. For example, in case of any injury, pain is generated at the cellular level. There are different mediators that causes the pain. then pain is conducted through the nerves, through the fibers, and then it is modulated at the spinal level, and finally it is perceived in the brain, in the primary area 3 to 1. So the main principle, the main objective of using multimodal analgesia is that choosing the medication, pain medication from different groups of pain medications having different pharmacology. For instance, you are using NSAIDs. It has a different pharmacology. It has different mechanism of action. You are using opioid that acts on the opioid receptors. You are using local anesthetic agent that is acting on sodium potassium nerve conduction, that stops the nerve conduction. So by using the different group of medication, you will get a better pain management, and the ultimate aim is to reduce the usage of opioid as much as you can by using the medications from different other groups.
Thank
Okay,
you.
sir, can I ask a question?
Yeah, sure, please.
Thank you, Doctor.
You explained that we can use lidocaine and dexmedetomidine in
Yeah.
trauma patients. So, have you some experience in using it?
In lidocaine, yeah, we have used it in the patients. It can be initially it can be given in a bolus form, later on in an infusion as well. Infusion is recommended to go up to 24 hours, not beyond that, and we have to monitor for the side effects as well. Lidocaine, if you're using lidocaine, it has beauty that it helps in preventing the neuropathic pain. Even in elective surgeries, for example, in midline laparotomies, it is recommended to use the lidocaine infusion, but not as a first or as a sole agent of pain management. And similarly, dexmedetomidine, it has a dual effect. It has a effect of analgesic effect, just like magnesium, but this analgesic effect is at the spinal level. So it provides analgesia, and it also acts as an anxiolysis as well. Just imagine a patient who has suffered from the polytrauma. Uh, that picture of trauma is usually stuck on the mind of the patient. And sometimes you see a patient coming to the emergency department screaming, and most of the time we take it that patient is in pain. It may be in pain, but sometimes it is because of the that picture, that video that is again and again repeating in his mind. The fear of losing the other members of a family as well. So if you are using dexmedetomidine, again, it is not recommended to use as a sole agent. It should be used in combination with the other medication. Again, it has a alpha 2 receptors effect. So again, it is acting there.
Thank you, Dr. Azhar. One question from the participants. Dr. Shad needs to ask for the trauma block, who should be performing that block? The emergency team, the anesthesia on call, or the pain nurse?
Yeah, now it depends upon the setup. Ideally, the people who are specialized in the emergency department, ideally they should perform the block, and ideally with the help of the ultrasound. If there is no ultrasound available there are number of other blocks that can be performed without the help of ultrasound. Again, the accuracy and the effectiveness will be affected. इतनी ज़्यादा नहीं होगी, but can be done. In the if there is no trained person in the emergency department, then obviously if a trained person present in the anesthesia team, that has to go for the block if they are free from their primary duties. But up till now I haven't seen any recommendation doing the nerve block by the paramedical staff. I haven't seen such a recommendation. um, but I'm sure in areas where there is there are very busy trauma centers, there must be some trained assistant physicians who are doing the blocks as well.
Thank you, sir. Another question, if we can use dexmedetomidine in patients who are already in shock after polytrauma.
Yeah, so it's better to avoid the use of dexmedetomidine because we know that it has a sympatholytic effect. Along with that, it causes bradycardia as well. So we have to tailor our things according to the patient. If the patient is already having a traumatic brain injury or the patient is in severe shock, then it's better to avoid it because it is recommended as an adjunct, but not as a primary analgesic medication. Even in, as I've mentioned in my few slides, that even if a patient is having badly injured patient coming with a polytrauma, and patients' blood pressures are on a very lower side. For instance, I'm sure we have all have seen such patients coming with a very feeble pulse, having blood pressure of 60 or 50 systolic, and surgeon has to go to secure the that injured site. So even in such cases, we avoid the opioids or such medication that could do the sympathetic tone further lower down, so as to avoid any mortality. So so it's better to avoid dexmedetomidine in such a situation.
Thank you, Dr. Azhar, and thank you everyone to all the participants who have come here. Dr. Mohammed wanted to ask if pain management for 3 month post TKR painful knee. He wanted to have a repeat query for the question.
Mhm.
Dr. Azhar, if you wish to add something on this.
Yeah.
Assalamu alaikum,
Uh,
Dr. Azhar. Yasir.
yes, sure. जी यासर, कैसे हैं
Yeah,
आप?
how are you? Alhamdulillah. Very nice presentation, mashallah, excellent. It's regarding the if you allow me, I can add the comment on the questions asked by regarding
Yes,
the
sure.
gabapentinoid.
Let me introduce Dr. Yasser. He is a anesthetist and a pain physician working in Riyadh. Dr. Yasser, please, you can add something.
Yeah, regarding your first question, comment regarding the use of gabapentinoids in acute trauma patients or post-surgical patients, it has been shown, as you mentioned, in the traumatic stress injuries, the various mechanism of gabapentinoids and various mechanism of action in the body through which it acts. It has a role in the acute trauma pain and also in the post-surgical pain. But we have to be careful about the timing of administration. It can lead to sometimes delayed awakening from the anesthesia, and sometimes it is associated with sedation. So in those patients who are likely to be get drowsy or sedated in the ER, having brain trauma or something. So we have to be cautiously used. But there, yes, there is a special role of gabapentinoids in trauma patients as well as the operative pain as well. They reduce the consumption of the and reduce the consumption of other medications as well, and leads to recovery. And also there is some uh, articles mention about they have reduced the incidence of post-traumatic stress disorder and persistent post-surgical pain.
Yes, exactly. Okay.
And the second,
Yeah. Would you like to comment on the TKR
yeah,
post-surgical
yeah,
after 3 months? Yeah.
yeah, I'm trying to comment on that as well.
Yeah. Please,
Regarding that
please.
post TKR, first of all, we have to rule out what is the pain in those patients, why they develop post TKR pain. Either it is an acute pain or it is a chronic post surgical pain. So, because the treatment strategy totally different on sites. Acute pain, which can be less than 3 months, and chronic pain, which can be more than 3 months, which is mostly defined in the most of the books. So depend upon what type of patient complain. Maybe surgical component, maybe tissue damage, maybe scar tissue damage, maybe formation of neuromas. That all depends upon the history and examination of the patient, and accordingly we have to treat those patients having post-surgical pain. As the we mentioned that patient comes to the clinic after 3 months. So it most likely develop post-surgical pain, chronic post-surgical pain. So in that strategy, there are various options. Either you go for the non-medical treatment, non-pharmaceutical intervention as well. We can do nerve blocks. We can do if the diagnostic nerve block proven at patient, we can go for the radiofrequency ablations for these patients, either cooled radiofrequency or pulse radiofrequency, or implant also can be. We can give them for the peripheral nerve stimulation. But these are advanced level. We have to first of all figure it out what is the um, anyone can also share their thoughts process in this.
Assalamu alaikum. Assalamu alaikum.
Salam. Dr. Salman, how are
I'm
you?
Ji, Alhamdulillah. I'm Dr. Salman from Islamabad. Thank you very much, Dr. Azhar. It was very excellent and comprehensive talk by you. And no doubt, the topic of discussion is a very challenging topic for pain management. And it's very difficult to manage a patient with polytrauma. I would suggest only one thing for our junior colleagues, that we should focus on multimodal analgesia in pain management of such patients. Dr. Azhar has explained what is multimodal analgesia. We should follow this policy. Thank you, everyone.
Yes, thank you, Dr. Salman Salim. Ji, any other question?
Well, yes, sir. We're taking the last one. Dr. Anis wanted to ask if we can use NSAIDs for bleeding patients, actively bleeding during the surgery.
So it's better to avoid the NSAIDs in a bleeding patient, or if the patient is having a risk of bleeding, it's better to avoid because it has an effect on the platelets function as well. Even you will send the platelets, the number would be fine, but the quality of the patient platelets would be dysfunctioned. So that would further aggravate the bleeding. So it's better to avoid NSAIDs.
Thank you, Dr. Azhar, for this fruitful discussion on this topic. I request every participant to fill in the feedback form and to email us any queries or questions which you guys need to be answered, which will be responded back appropriately. Thank you very much, all.
Thank you, Dr. Abdullah. Thank you, everyone.
Thank you, Dr. Azhar. Thank you.
Thank you.